Good afternoon, ladies and gentlemen. It is time, but I want to check if we have all the speakers here. I'm missing speakers from Ethiopia. Anybody here from Ethiopia? Okay, my lady friend at the back is doing the presentations. If we have to change the order, I'll let you know. All right. So good afternoon, everybody, and welcome to this session, which I don't know how to introduce it because it looks a complete hodgepodge of all sorts of things. But by and large, looking through each of the topics, it looks that you're going to discuss implementation challenges, and I think that's really, really exciting. So I'm not going to spend time discussing anything at this stage because I would like the discussion to come from you. I'm informed by the organizers that everybody has 8 minutes. So it's very short. It's a very short time that you have. And I will give you a signal and say your time's up. So we have to be able to fit it into the hour and a half. We do need to keep to it. If you feel your presentation is longer, perhaps you can just skip some of the less important things, but highlight the things that are really, really important that you would like the audience to hear and know about. And I'll be very happy, and I'm sure that everybody else will be happy that you do that. So without any more ado, I would like to call on our first speaker, Nora Engel, who's going to speak about barriers to point-of-care testing in India and South Africa.
Thank you. Can you hear me? Yes, otherwise, okay, I have to figure this one out. Okay. So, thank you very much. I'll report on a project that we did on barriers to point-of-care testing in India and South Africa. This was a qualitative research project where we were interested to understand what are the biggest challenges in making point-of-care testing successful across different healthcare system settings, basically where patients interact with healthcare providers. And we did not focus exclusively on one disease. We just focused on the diseases that the people were dealing with in these settings. So this is not a talk exclusively on tuberculosis. I apologize for that. If you, we did a lot of interviews with different healthcare providers, with lab technicians, program officers, patients, and we talked to them basically about the processes that they were going through in diagnosing these major diseases that they were dealing with. And the challenges that they were encountering at each step. And we did that because our understanding of point-of-care testing was a rather process-oriented one, rather than one that is centered around a specific product. We defined point-of-care testing as successful if a patient encounters the healthcare system and leaves that encounter with a management decision based on a diagnostic test result, if needed. And that encounter can be, an hour, but it should be at least within the same day. So that is how we defined it. That means the focus was really on the diagnostic processes that people went through. So we published results for each of the countries separately already, and at least 2 or 3 more papers are coming out. What I want to do today is just to take 3 points that we can draw from when we look at the 2 countries together. The first one is probably a very obvious one, but I think important to realize. The 2 countries we studied have very different diagnostic ecosystems. Diagnostic processes are very differently organized. And consequently, the challenges to point-of-care testing, as defined in our study, are linked to this difference. So in South Africa, there's a lot of more centralized testing going on. It is the sample that travels from the clinic to the laboratory, and then reports travel back. In India, you have much more peripheral testing, both in public and private sector, and it is the patient who needs to travel. The patient needs to go to the laboratory, provide the sample, and walk the result back to the treating provider. So the patient is the carrier of everything, the sample, the results, but also the communication between the providers. Secondly, the strategies that healthcare workers and patients apply to overcome the specific challenges are often very fragile, ad hoc, and most of the time not very sustainable, and at worst can sometimes further disrupt these diagnostic processes. And thirdly, patients embody rather active roles in managing their own diagnostic journeys, more active than we would sometimes expect. I'll give you a few examples. I hope I have enough time to just illustrate these 3 points. So as I said, South Africa has a rather centralized testing system. Those tests that are sent out to central labs are expected to come back within a day or two. But because of transportation, problems with transportation, leaking or low quality of samples, there's often additional delays that are being accumulated according to the providers we talk to. And then, of course, results need to make it back into clinics and be acted upon. And again, you can have additional delays there. So one of the strategies of dealing with these problems was that many healthcare workers would actually artificially prolong these turnaround times even more. They would tell their patients, why don't you come back in a week, because then I'm really sure the result will be there. Another strategy was to call the laboratory for lost results, and thereby you're interrupting ongoing laboratory work. Or clinicians who drive out the results to clinics that they're visiting on an ARV day. Of course, that puts a strain on very scarce human resources. So you see how the strategies can be fragile and sometimes disrupt things even further. Not all tests are sent out to centralized labs. In South Africa, you have a number of tests that are conducted on the spot. Very prominently, of course, HIV rapid tests. And those can usually be made to work within one encounter. However, there were challenges there as well that led to disruptions. For instance, HIV test kits are often out of stock. And providers told us that in order to manage these stockouts, you have to keep up very good relationships with other NGOs, other clinics, a hospital, a government official. But in order to maintain these trust-based relationships, it's very challenging in a context where you have a high staff turnover. Another example to show you how actively patients actually manage their diagnostic journeys is HIV clients very often very specifically decide they want to get tested at. So they might choose a clinic that is further away, where they have to present with the wrong name. But they choose this clinic because they have considerations about cost, distance, time they're going to wait, or stigma that they expect. Or they might present with a different identity in order to maybe access a different result, to get a job or a grant. Or they might present as new clients, although they're already on treatment, in order to access the single pill, etc. So patients are really actively engaged, and they need to make their diagnostic journeys worthwhile. In India, you have a much more peripheral testing ecosystem going on. Patients need to make these travels between labs, and they often bounce around. We've heard that in several sessions at this conference. And you can imagine when you're very poor, when you have very low resources, you might opt out. You get frustrated, you give up. It's too frustrating, confusing, it takes too long, too costly, etc. In the private sector, private providers try to make these travels easier for patients. They have arrangements with labs next door. They adjust their opening hours. They send them to a lab that they're friends with. But then also they get referral fees back for that. So in one way, it makes it easier for the patient to complete this journey in one day, because he or she can go back to the doctor that evening. But it might also incentivize ordering unnecessary tests, because the doctor gets a kickback for each test ordered. Or doctors might actually choose to not even send their patients out for diagnostic tests, because they want to just not send them off onto these costly and frustrating journeys, and rather treat empirically. In the public sector in India, you have at each clinic, you have a laboratory attached with a lab technician, a few nurses, and a doctor. So you would think these are ideal grounds for making point-of-care testing successful in the way we defined it. But we found that very often, actually, patients ask to come back the next day or in 2 days for results, because the lab is overworked and the turnaround times are too long. Or actually, clinicians might not even ask for investigations because they know the lab is overworked. And that happens also in a context of extreme resource scarcity. So where there were rapid tests available, they were often out of stock, or the budgets ran out halfway through, etc.
You have 1 minute.
Yes. So we summarized the dynamics in India in this graph, and the only message I want you to take away from this today is that the patient is at the center of activity in this ecosystem. He or she has to finish these journeys, and that can be very frustrating and difficult for patients. So these were my 3 major points. Challenges to point-of-care testing are linked to the way in which diagnostic ecosystems are set up. Strategies to overcome these are often locally negotiated solutions, ad hoc. They rely on personal commitment, relationships, and at times they can lead to delays or disrupt these processes further. Patients embody very active roles. That is very clear in India. The onus is entirely on the patient to complete test and treat cycles. But also in South Africa, patients acquire the ability to return for counseling or follow-up sessions, and they need to make these journeys worthwhile for themselves. They need to fit into their lives and their other concerns. So if we're talking about barriers to making new tools work or barriers to point-of-care testing, we have to realize that we cannot separate these things out, because material or infrastructure challenges, but also relationships between providers and the way diagnostic processes are organized all relate to each other. So they need to be studied together. And that is why we would argue it is so important to not only study how patients seek healthcare, but to actually study the processes that unfold in diagnostic journeys, both for healthcare providers and patients' perspective. That's it. Thank you very much.
Congratulations. Okay, thank you. And I understand you have to go.
Yes, sorry, I forgot to say I have to leave because I underestimated the time it takes to travel to Manchester Airport. I'm sorry, but I'm happy to take a few questions if you allow.
We will allow one question because of time. Is there any burning question that anybody would like to ask? I think not. If you think of it afterwards, they can email you. All
Yes,
right?
please, always.
Yes, her
Yes.
email is up here.
Okay.
Okay, thank you very
Thank
much
you so
and
much.
safe travels.
Thank you.
Our next speaker, I hope, is from Ethiopia. Is it? It's Debo, right? Okay. And Debo is going to speak about task shifting in the TB laboratory and the experience of using non-laboratory technicians in 2 regions in Ethiopia. So you have 8 minutes from now. I'll give you, when 1 minute is near, I'll let you know.
Okay. Thank you very much. So I'll be talking about task shifting in TB lab service delivery, an experience from Ethiopia. So we usually don't talk about task shifting in lab work, but because of the challenge, now we have started moving and using experience from other programs and other healthcare cadres. So this work was done in collaboration with the Ethiopian Ministry of Health and the National Laboratory with support from the USAID Heal TB project implemented by Management Sciences for Health. So to give you a bit of background about the TB program, we have a comprehensive program in Ethiopia. We have been implementing DOTS in Ethiopia since 1996, and but one of the critical challenges, even with the availability of resources ensured, we still have a challenge of diagnostic facilities in the country. Sometimes you have a microscope, a very nice one, but you don't have the laboratory professionals to do the job. So you end up having an equipment without the right personnel. So this has been a very critical challenge, and we started thinking how to address this issue in addition to training people. So one challenge which led to the shortage of the laboratory professionals in Ethiopia was that the Ethiopian Ministry of Education decided to scale down the training of laboratory professionals based on a wrong estimate that we had saturated the lab technicians that are needed for the work. So, but after some time we started to experience this, and it takes at least 3 years to get another person trained. So what was done was the regional health bureaus, in consultation with them, we discussed on another option of using non-lab technicians to improve access to lab services. these are the interventions. We have two categories of health workers who did the role of a laboratory professional. One is nurses, HEWs. These are health extension workers. These are community workers. They have only 1 year of training as frontline health workers, and their primary role is doing preventive work in the community. It's not laboratory. It has nothing to do with lab. So what we did was we trained in one of the regions the nurses because they were available in large number. But in the other region, we didn't have even nurses to do this job. So we ended up training health extension workers. We prepared training material and trained them on basic TB symptoms and signs, basic skills of collecting and fixing sputum smears, and how to transport them using a safe system to the diagnostic health facilities, which are available in the nearby health facilities. So then after sending them, the lab technicians and the lab technologists in the diagnostic health facilities received the laboratory, the fixed sputum smears, and they did staining, and they examined them for FEV, acid-fast bacilli. So the result is summarized in this table. These are presumptive TB cases referred, and the yield of TB by a professional category. You see smears done by a number of presumptive TB cases with slide smear fix and sent by health extension workers. There were 328. Nurses did more. This is more than about 20-fold or 25-fold compared with the health extension workers, because we had a limited number of health extension workers trained to do this work. When you look at the number of total slides processed as the diagnostic health facilities, 900 by the health extension worker category, and over 23,000 by the nurses category. These numbers, we are not comparing them because they have nothing to do with the yield of the work. They are done over a different period of time by different number of people. But when you look at this number of samples processed per patient, we did 3 per patient. You can see the numbers there. So when you look at the slide positivity rate and with the confidence interval, the smear done by the health extension workers, it was 3%. In the nurses group, it was 2.07%, but the average is 2.1%. So when you look at the yield of TB, overall, 2.7% in the health extension group, 2 in the nurses group, and 2.05 overall. So using this system, we were able to diagnose, identify 174 TB cases and initiated them on treatment. When we compare it with the smear positivity rate from the by the lab professionals, there is no difference. So,
You have 1 minute left.
okay, I'm there. So, so in conclusion, if we don't have a laboratory professionals to do the job, we can train and use non-laboratory professionals using very simplified operational guides, and that can be a temporary solution. Task shifting has never been a permanent solution in any other program, but for temporarily we can fill that gap. So the smear positivity rate also recorded is also comparable. We think we are giving the same level of quality, but we need to dig into details if we have to do further analysis. If there is a proper referral system in place, I think this can be successful in any other country facing a shortage of laboratory professionals in the system. Thank you.
Thank you. We'll keep questions to the end because we have a lot of presentations to get through. Our next speaker is Stephen Neri on field testing of TB sputum specimen optimizer in Malawi.
Okay, good afternoon, everyone. My name is Steve Neary. I'm Regional Director for Project HOPE. So that means I oversee our operations across sub-Saharan Africa. And I'm very happy to be here to present our field test findings for OmniGene. So the background, basically, one of the challenges that we have for accurate TB diagnosis is transporting sputum to diagnostic laboratories. And so for many of us, we're trying to get improved diagnostics out further and further to peripheral sites. But still, there is an issue with transporting sputum from even further out to a central point. And so in order to get the sputum from rural areas up to a district hospital where you may find an expert platform, either you have to have the sputum has to basically be transported in a cooler box, and depending on how the sputum transport system is working, it may be waiting for a longer period of time. And so the OmniGene reagent is designed to liquefy and decontaminate sputum at the point of collection, and it's supposed to maintain the viability of the sample for 8 days at ambient temperatures. At the time that we undertook this field test, there was bench conditions that supported the use of OmniGene, but it hadn't really been tested in an area like Malawi before. So our objective was to evaluate whether OmniGene sputum can maintain quality of sputum samples from peripheral collection centers to a centralized expert testing center, and we tested it against the standard of care. So we used a quantitative comparative study. Originally, when we were setting it up, we were thinking we would try to split one sample, but early on we abandoned that, and we ended up collecting 2 samples from each subject. And both of the samples were tested with expert using the H2 standard, and the samples were treated directly with the buffer, and there was no centrifugation. So it was conducted across 7 districts in Malawi between November 2015 and February 2016. The sample size was 377, and we obtained ethical clearance from the National Health Sciences Research Committee. And so, I mean, basically, to summarize, it worked. The standard of care was to use cooler boxes and transport the sputum to a central point. And when we tested that against using the OmniGene, we found that it was comparable. So a couple of points, we did find 2 additional cases. I think you can see that from the previous graph here in the table. There were 2 additional cases that were found by OmniGene. The OmniGene sputum treatment of samples, it didn't cause any increase in errors, so it was comparable. And you know, our conclusion is that OmniGene sputum sample optimizer, it's a good alternative to store and transport sputum samples from peripheral locations to a central point. I want to acknowledge the Ministry of Health in Malawi, the National Health Sciences Research Committee, TB Reach, and DNA Genotech. And I put a little disclaimer here. I was not the one to be presenting today. My colleague, Wandusen Asafa, was supposed to be here. Obviously, he's not here. He was unable to present because his visa application was rejected, and really it was for silly reasons that had nothing to do with anything other than a reflection of the current climate here. we would hope that in the future the conference organizers would sort of anticipate this and put something in place to ensure that people from around the world can come and present their work.
Thank you for putting that in, and thank you for the presentation. We all agree. I think there are other countries here. Ethiopia has many of the staff didn't come for the same reason. So there were a lot of people. I hope that people will write into the union and ask them to do it. Thank you so much. You're on time, so you're good.
Thank you.
Thank you. We'll take questions at the end.
Okay.
All right. The next speaker is Kehinde from Nigeria. Cost-effective technology improves distribution and management of logistics commodity for drug-resistant TB testing in Nigeria. Okay.
Yeah. Good afternoon, everyone. My name is Kehinde Jimo Agbayero. I work for the Health, Finance, and Governance Project, an apt project in Nigeria. I'm a senior TB technical advisor for the project. So I'll be presenting our work that we did in Nigeria. And that's cost-effective technology improves distribution and management of logistic commodity for drug resistance tuberculosis testing in Nigeria. Well, we work together with System 1. This is a project that we piloted in Nigeria, and I think in so many countries now, close to about 15 countries, GX Alert is used for DRTB, for quick response to manage a DRTB patient. So the outline of my presentation will be in this format: the background, challenges to intervention, value of integrating the GX Alert application, implementation of the innovation, then the results and lesson learned. Well,
Can I stop you for a moment? You have a lot. Highlight the important things because you have
okay.
like 6 minutes left.
So no, I'll manage the time.
Okay.
Yes. Well, basically, this is a background on where we are currently in Nigeria. The population is about 165 million, and the MDR prevalence among retreatment cases is about 14.3%. We have currently 210 gene expert machine, and we're innovating the GX Alert technology. Now that countries are moving to using gene expert tests as their main point of diagnosis, it's important for countries to also think of how to manage their logistics in terms of the cartridges, which I will talk about, and we'll see some of the results we're able to come up with. Basically, GX Alert is a software that's configured on a gene expert machine, okay, that allows real-time reporting of all test results, then can analyze and aggregate cartridges, the utilization of cartridges, move cartridges to where they are needed, and also prioritize them, So that's what GX Alert does. Well, why I think we need GX Alert and Gene Expert machine is because it's difficult to move results to a central point. Looking at a country like Nigeria, which have a huge land mass, and having Gene Expert machines spread across the country, it's difficult to pull together the results or to know how cartridges are being utilized. And sometimes it's difficult, facilities sometimes don't have cartridges to run their test. And that's why we came up with this system. So basically, this is what I just described now. From different points, results can be moved to a central database, and it can also send SMS alert notification. A GX Alert can be integrated with other systems like the ETB Manager, the DHIS2, then monitor cartridges, collect custom data, which by default the Gene Expert machine cannot collect. Custom data like the HIV status, the age, sex, and sometimes the address of the patient. So that brings me back to one of the modules that was developed together with System 1 in GX Alert. That's the inventory module, which looks at the days of supply by stock and location. You can actually look at that. It's a real-time information. You can tell how much stock you have in a particular location, across the country. And when a stock is going to expire, you can actually see it there so that it can be prioritized and taken to other facility. The other thing is you can know the amount of stock you have. Well, this is what you can see on the GX Alert dashboard, in terms of the stock at hand by location, so that if you need to move stock from one facility to another, that can be done. Of course, you can see the location there. So basically, these are the results we came up with. As of 2015, January 2015, we realized that the forecasting and redistribution of cartridges was well improved, and it jumped from about 50% to 75% out of 35 facilities as of January 2015 in terms of the distribution of cartridges. Then we were also able to identify over $100,000 commodity cartridges, that would have expired before they were used. And of course, the NTP quickly reallocated them. Then of course, it gives real-time information on the uploads from GeneXpert machine. The good news is that once a test is done, the deduction is done automatically because of the GX Alert software that's on the GeneXpert machine. Well, just to quickly summarize this, we did a simple cost analysis to look at the benefit of using this system. And of course, we look at the cost of the GX Alert modem, looking at the Glow modem, that was used initially. Now, we have gone further to use routers, which is more expensive, but this is an analysis that was done some time ago, And of course, we look at what it would take to develop the dashboard, the logistic module. Then, of course, looking at other costs. And now, if you compare that to the total amount that you will spend, you realize that you'll be making a lot of savings because if you have to calculate losing about 100,000 K of cartridges, yes, losing about 100,000 K of cartridges and spending, roughly about $35,000 to $40,000, and no other additional cost outside maybe the subscription for internet for a country like Nigeria. So the take-home message here is that GX Alert eliminates human error as cartridge forecasting is done automatically. It pinpoints facilities that need immediate supply of cartridges and those with more that they can use. GX Alert also strengthens and improves programmatic decision for cartridge procurement, distribution, and management. Then, of course, it's a tool that is used for notification of all GeneXpert testing, and we suggest that it is scale up because this can be done locally and in country. Thank you so much.
Our next presentation comes from Ethiopia, and your name, sir? Okay, because Malukon is not here, another person who couldn't get his visa to come, so we're doing that. Electronic laboratory specimen referral system in Ethiopia. Yes, this is the right one, is it?
No.
No? Yes.
Yeah, thank you, Chairperson. Like mentioned, one of my colleagues was not able to attend due to visa problem. He is a veteran public health specialist, but he was denied. So I am going to present about electronic laboratory specimen referral system in Ethiopia. It's just an early pilot stage, and we'll discuss the way forward. In Ethiopia, there has been no mechanism to transport samples without compromising quality, but recently our Ministry of Health liaised with the postal system, our national postal system, to transport, sputum samples from referring facilities to laboratories located at the centers. And the postal system, they use triple package. They have infection control mechanisms, but still, the sputum samples are transported using, vehicles that are public transport or, government-owned transport without any cold chain mechanism. But they use, hand carry cold boxes to transport the sputum sample from health facilities to the lab. And not only that, result also takes few or sometimes months to reach to the health facilities, from the testing sites to the referring facilities. It takes up to 2 or 3 months sometimes, to receive the result, because the postal system, they do not have, frequent linkage with the testing laboratories. So to tackle, the communication problem, because, the referring facilities and the lab and the postal system, they are communicating by personal phones or, physical contacts. Our project, through USAID support, piloted a web-based and mobile short message service, sample referral, and real-time result delivery system. And the e-specimen system was piloted in 24 health facilities that were linked to 24 postal systems and 11 laboratories. As you can see in the figure, when the health facility has, sputum samples to be referred to the laboratories, they push, SMS sample so that the postal people receive, information that the referring facility has sputum samples, to go to the laboratories. And once the postal system or the postal focal persons, receive that message, they go to the facility, collect the sputum sample, and transport the sample to the testing laboratory facilities. And when it reaches to the laboratory technician also enters, all basic information, and also, is coded for each individual. Then once the result is ready, the result will be delivered to the referring facility through SMS, whether it is positive or negative. But at the same time, the postal system also provides, the hard copy. In case the electronic system is not working, there is also a hard copy mechanism so that the postal system can, transport back the lab result to the referring health facility. So this was tested in 24 health facilities. We know that our, internet connection and some of the SMS mechanisms are not well, established, but still we saw, encouraging result from our pilot study. So in the 24 health facilities, during the pilot period, we might focus on our sputum transportation. And as you can see, GeneXpert request was made, for 282 samples, and around 232 samples were received by the lab, and lab result was ready for 224, samples referred to the facility over the pilot period. And when it comes to culture, out of 693 refer samples, at least result was ready for around 411 of them, which is 62%, which goes with, with the lag time for culture lab result availability. So we have seen that the web-based as well as, text message system functioned very well, despite, our less access to those facilities at the referring facility, the couriers, and the testing centers. Earlier on, they were communicating informally by, personal phones, and other mechanisms, and we have seen that, our system has functioned very well during our pilot period. And for GeneXpert sample that has, lower turnaround time, 82% of the samples of the patients received their result in less than 4 days of sample delivery, which was, maybe 7 days, 10 days before our pilot study. And it was very good for, our quality of care and to start our patients on time on treatment. And there was, and also, like I mentioned earlier, we have been using our postal system, and they were carrying, the samples by hand using cold chain boxes. But our project, through USAID support, also introduced, cold chain vehicles. Although it was not part of our pilot study, I just wanted to project our support to our government in providing, cold chain mechanisms rather than, using the traditional hand carry mechanisms. And we are going to pilot also this one. Actually, it's being implemented, and we are going to report the finding in the subsequent union conference and publications. In conclusion, the pilot demonstrated that e-specimen referral system is feasible, rather than people communicating informally from referring to the lab and from the lab back to the health facility. We have created, SMS system as well as even in the internet. If they have access to internet, facilities can access the result from the internet without waiting from, from the lab. So it has significantly improved the sample transportation and quality and timeliness of lab result delivery, and we recommend to study the cost, turnaround time, and specimen quality in the future, especially comparing, the traditional postal delivery mechanism versus our cold chain vehicle mechanism. Yeah, thank you for listening.
Thank you very much indeed, and thank you for keeping good time. Our next presenter I'd like to call on is Michael Murphy, who's going to talk about increasing TB laboratory capacity. Can we reduce the incubation time of midgets?
Okay, yeah. So I have to dash off after this, so if there are questions, you could just ask me. Yeah.
You can be quicker then.
Yeah. So okay. Yeah. Okay. So so the World Health Organization advises that all samples be confirmed in culture, but the protracted time that it takes to report either positive or negative of up to 6 weeks is problematic and is difficult for laboratory capacity. So we were interested to see if we could reduce midget incubation times, because they've obviously been shown to have greater sensitivity, but also reduced time to detect a positive result. So obviously, whatever that's like. As part of the REMOX TB study, we looked at all of the samples that we collected. So this was a randomized, controlled, double-blind trial comparing 4-month regimens containing moxifloxacin. And the important thing to note for this is that all of these patients were smear positive before they came into the study, which is important for the topic under discussion. So all patients had 2 pre-treatment samples that were positive, 2 pre-treatment samples, and then they had samples collected weekly during the intensive phase and monthly samples until the end of treatment. And all samples had smear microscopy and culture in both liquid culture and an LJ. So we had 20,600 samples collected from 1,900 patients. And you can see here on the left-hand graph that the red line is depicting midget culture positivity. So you can see that midget samples are much more sensitive than LJ at all time points. And that's important when you're thinking about time to detection and capacity, because obviously at week 8, rather than having 15% positive LJs, you now have 40% positive midgets. So increasing the number of samples that you're going to have there. On the right-hand side, you can see that the mean time to detection, the median midget time to detection was 11 days. But this changed considerably on treatment. So pre-treatment samples, the median time to detection was actually around 6 days, with an upper limit, with a 75% quartile of 16. But you can see that increases, the black line increases as time on treatment rises. But when we looked at comparing these differentially, so you can see now that in the dark slides are pre-treatment samples, and the lighter slides are samples taken at week 17, which was the end of the study drug. You can see that the dotted dark line is a cumulative result, and you can see that it's nearly at 100% at 14 days for the pre-treatment samples. But when you're looking at samples taken later on, and this is true for all of the time points, you have a much lower detection rate within a shorter time period. So you're not getting really until over 95% until 28 days have elapsed. But obviously, pre-treatment samples in clinical practice are vastly the most numerous sample, because obviously most samples will be negative. When we looked at the sensitivity of using different cutoffs, so in red we can see the sensitivity of using a 14-day cutoff was 98%, and that sensitivity didn't really go up at all, no matter how far you went out with the cutoff. So you can see at 42 days it's just the same. But at week 8 and at week 17, you can see that if you were to use a 14-day cutoff, you would get a vastly reduced sensitivity, and so that cutoff wouldn't really be feasible if you're using culture monitoring as part of your treatment monitoring strategy. So the conclusions of this work are that for pre-treatment samples, the sensitivity of midget culture does not increase by extending the culture beyond 14 days. And that during treatment, reducing that incubation time would mean an unacceptable loss of positive results. So you have this sort of numerous diagnostic samples, and if you were able to reduce the midget incubation time, you could increase the laboratory capacity. And obviously, if you reduce it from 14 days to 14 days, you can treble your laboratory capacity. That's important because you have a midget 960 is a very large machine that takes up a lot of space and requires a lot of electricity. And there is now a smaller midget 320, which is a single drawer, so it's more feasible for implementation. And you could, if you reduce the time to detection, a midget 320 would give you the same capacity as a midget 960 for diagnostic samples. And also you'd be able to think about decentralization, because obviously samples at the moment for culture are often centralized, but you can see with expert and things that decentralization has been a useful thing. And actually, if you had a smaller machine, you might be able to decentralize that. But I think that the most important thing to take away really is that these results were confirmed in patients who were smear positive. So you would need to think about whether patients with smear negative would have longer times to detection, although you can get down to very, very low sensitivity, like 10 microbacteria within 28 days. So most patients will have a lot more than that. So quite possibly would still be positive within the 14 days. But as I say, that's the most important limitation to remember.
Okay, thank you. You have 1 minute left. So
Any
we can
questions?
take one question. Yes. Can you come to the microphone, please? It's not on. Can you speak up louder?
Yeah, so there was some talk earlier on about actually patients with low-level rifampicin resistance or low-level bedaquiline resistance actually developing longer after cultures, and there have been some studies showing that you do get an increase if you continue, if you continue to 12 weeks with actually the maximum sensitivity. I suppose it's difficult. We don't really know what all of those low-level changes mean, and I suppose in terms of thinking about capacity, you've got 50 million diagnostic samples a year, and you only have this amount of laboratory space. So it's thinking about increasing your turnover, but obviously you would then potentially miss all of those populations if those do turn out to be important. But we don't know that yet.
Thank you. A quick comment from Kathleen, please.
Mm. Mm. Yeah. So I think that during treatment, I think it is really important that these happen. Mm. Yeah. So all of these patients were drug sensitive within the REMOC study, but yeah.
Thank you very much. Very interesting, and I'm sure there'll be a lot more discussion on this. Thank you. I haven't identified the next speaker. Do we have the next speaker from Nigeria, Mr. Kuzera? Can I ask at the back for our organizer there? Do we have his presentation? Which one do you have next? I'm sorry, I can't hear you. Can you put up the one that you have next till we find out? I'm missing two speakers. Yes. Introduction of second-line DST testing in Swaziland. Is this the one? This is the one. Slightly different from what. Yeah. Okay. This is Google.
Yes, wow.
It's all right because the original. I apologize, everybody. The original list of names is different because of people not being able
To
Would you
make
mind
it.
to introduce yourself and say who you are?
Okay, let me just stand aside so people can see me.
Yes.
So my name is Welile Sikonze. I'm presenting on behalf of Gugu Mapalala, who is the principal laboratory technologist at the Swaziland Health Laboratory Services, and couldn't make it this week, as with many people.
Okay, we're pleased that you're here.
Thank you. So I'm presenting on behalf of the Swaziland Health Laboratory Services, although I am from the National TB Control Program and a medical practitioner by training. So I'll try to answer some questions, although not in a lot of detail. So just to share some epidemiology about Swaziland. Swaziland is a small country bordered mainly by South Africa and Mozambique. It's a high TB HIV burden country, as well as a high DRTB burden country within the region. Our last drug resistance survey, which was conducted in 2009-2010, revealed prevalence rates of 8% amongst our new cases and 34% in previously treated cases. This was a follow-on from the Tugela Ferry outbreak, which took place in KZN in South Africa, which spurred on the need for the country to conduct a rapid assessment of the availability of drug susceptibility testing for TB patients in the country. In addition to this, during the previous DRS, we are currently in the planning stages of a follow-up drug resistance survey. We discovered that there is a mutation circulating in the country conferring rifampicin resistance, which accounts for 30% of our cases, but is outside of the RPOB probe, so is missed by gene experts, and this required a revision in our diagnostic algorithm to ensure we were still catching those patients with RR who would have been missed on gene experts. So the country has been implementing gene experts as the initial diagnostic test for presumptive TB cases, regardless of their HIV status or history of previous treatment. And previously, we also had a first-line DST in the biosafety level 3 laboratory at the NTRL. And as of February 2015, under the supervision of the Uganda SRL, Supranational Reference Laboratory, they then worked with the country to develop capacity to conduct second-line DST. So this is an activity that was identified as at Q1 2015 to provide second-line DST for kanamycin, amikacin, Capra, and oflafloxacin. The method that we use in country is Bactec Midges 960. We use liquid culture. We have not yet implemented solid culture. And at the time, 20 TB-positive isolates were identified, aliquoted into 2 parts and distributed between the 2 laboratories. And then the reproducibility of the results were compared between the 2 laboratories, the NTRL in Swaziland and our SRL in Kampala. So the findings of this assessment or this testing of the implementation of second-line DST showed that the same sample showed 100% reproducibility and sensitivity for amikacin, caprio, and kanamycin, and 80% for offlow. Thus, accuracy for mutations or resistance in susceptible strains shows validity of the midget second-line DST in use, and that second-line DST midgets is a reliable method for extra XDR TB screening because it was able to show reproducibility of greater than 95% for majority of the drugs that are currently in use in the country. So based on this, we then expanded the diagnostic algorithm to ensure first and second line DST was available to all TB patients. In that first line culture and first line DST is available for all MTB detected patients regardless of their rifampicin resistant status. And those patients who are detected on GeneXpert as having RR are then included in the algorithm for second line DST as well. So as I mentioned, we have Cana, Capro, and later on, we replaced offlow with Moxie and Levo. And these are the diagnostic tests that are currently in place at peripheral level and at the NTRL. GeneXperts, smear microscopy for follow-up testing, and then the midgets as well. So in terms of the uptake, there have been challenges since with the expanded diagnostic algorithm in terms of uptake of the different diagnostic tests. But mainly we're seeing that the use or utilization of the methods for second-line DST are quite good, and it's increasing in the country's capacity to diagnose early extremely drug-resistant TB. We've seen a reduction in the turnaround time. Previously, we used to send samples to NICD in South Africa, Johannesburg, and there would be a longer turnaround time for our results to be received and for patients to be treated or for treatment regimens to be changed appropriately. So we've seen a massive reduction in our turnaround time, although we are still heavily reliant on national sample transportation systems, which is an internal barrier for quality indicator monitoring. And with the planning of the second drug resistance survey, we are hoping to build capacity for routine drug resistance surveillance in the country without the need to conduct sentinel surveys moving forward. So all in all, this has been a positive experience for the country and has increased the number of patients who are accurately diagnosed with XDR and appropriately treated on the new drugs as well. And the same method for implementation of DST is being considered for implementation of second-line LPA, as we do already have first-line LPA in country. Thank you very much.
Thank you. Very nicely presented for somebody who's done it. We'll take the questions afterwards.
Okay.
Is that all right for you?
That's fine.
Okay. The next speaker is Catherine Fielding, who's going to speak about this program support from concept to reality.
Thank you. I must admit I feel slightly ill-prepared for this because the guidance when I created these slides said that we must stick to 4 slides only. But
That's all right. So you have 4 slides.
I've only got 4 slides, but I'll try and talk through them as much as I can. So the study in question was made possible by the Bill and Melinda Gates Foundation, also Google, and the Paul Allen Foundation as well. When we look back at connected diagnostics, probably started about 6 years ago, one of the issues that we saw was that the connectivity capabilities from the diagnostics were being primarily driven by the manufacturers themselves. And as a result of that, what we ended up with, although digitizing the data that we now know and love, the capabilities of the data reported was limited specifically to the manufacturer's own machines, i.e. the portals that they had created. So within a laboratory environment, what we ended up with was users having to log into to a portal to see GeneXpert data, to another portal to see CD4 data, for example. And that, of course, again, whilst we achieved digitization, we were still seeing fragmentation of the entire system. So one of the things that FINE did was to embark on the development of the Connected Diagnostics Platform, CDP, as we know that. And the aim of this platform was to be capable of ingesting data from multiple diagnostics, regardless of manufacturer, regardless of disease, and regardless of care setting. And the primary purpose of this was that we would aggregate that data centrally in the middle part of the diagram that you see here, and then push that data to applications such as medical records and surveillance systems as required. During the early years of this, one of the things that became very apparent was that despite the many requests for the data to be routed to those applications, many of them didn't really exist. And certainly when we were, for example, dealing with the Ebola outbreak that we witnessed last year, the database of many at the time was called Microsoft Excel. And so what we did on top of that was to build what we thought was a usable workflow and a user interface. But in the context of TB, what we did was to connect a number of devices, experts and Midget. But not only that, we digitized the paper-based forms that are commonly used or mostly used throughout healthcare systems in order to achieve the digitization of all of the tests, not just the digital format platforms that we know of, such as Expert. So in terms of the workflow, we adopted this around a patient-centered approach. We did feel that it was imperative to have a means for the test results to go back to the patient and for both the patient and the clinician to be informed of that. And what we were seeing previous to this was a number of sample-based systems where tests were merely being counted by themselves. Now, when we look at TB of a patient, if they are unfortunate enough to have multiple episodes of the disease in their lifetime, will have multiple encounters also with the clinician, and during those encounters we'll have multiple samples taken, and against any one of those samples we'll have multiple tests being performed. And simply counting those tests at a numbers level didn't really give us the burden or the disease burden that we were looking at. So the system that we designed, again from the donors that I mentioned earlier, with the patient at the center of that, we were able to harmonize or certainly reduce the duplicate records that we saw in the study sites, and without patients being registered numerous times across possibly various clinics and facilities as well. And against the patient, we would create the episode, and in certain systems where payment for the tests was being required, we accommodated that. Where samples were being collected and assigned IDs, we were able to merge these together from when the sample was taken to the lab, so that again we could allocate all of the results back to the patient. At the same time, creating alerts, and as the laboratory was processing these, again they were running the tests, and as soon as the test results were available from the connected diagnostics, they were making their way back to the clinician and also the patient as well. But where the platforms were not connected, i.e. microscopy or culture, for example, the digital forms were available for the lab techs to fill in, which certainly gave us the capabilities around the connected diagnostics and the alerts and such that we were seeking at the time. Now, just in terms of some of the central results from that, we looked primarily at the reduction of the reporting times. These studies were carried out over 3 countries, in Peru, Vietnam, and India last year. There were 4 device types that we looked at. These were gene experts, microscopy, culture, and LPA. 9 sites, and we collected 1,912 results at the time. Where the sample collection, referral, and testing was all done in the same facility, we found that the average reporting time for the results to make it back to the clinician was approximately 5 days, where the sample had been referred to another site, we were seeing on average a 14 or 15-day turnaround for the results to make it back to the clinician and the patient. With the use of connected diagnostics, we observed a time of approximately 10 seconds for those results once the data was available. And we would hope that the loss to follow-up would be reduced thereafter. But just goes to show that various metrics can be utilized from connected diagnostics. Reporting times is just one of them. But there are others that are possible to collect. And we're also looking at the number of duplicate records. The patients, of course, present themselves at different sites, the payment turnaround time, sample collection turnaround time, transport time, rejection rate, and time and reasons for that. Initiation and approval time as well. Approval time was actually one of those things that was quite interesting, even though the results were available. What we saw was at least a couple of days in certain sites before the lab manager would actually get around to approving them and making them available for release. But with the electronic systems, we can now prompt those users to go into the systems and review and release them. Test reporting time, total turnaround time, also monitored and can be monitored as well. And it's some of these metrics that we're hoping that will make it into the metrics and performance details that are now being promoted by the GLI and the WHO. So that concludes. That's 4 slides only. Thank you.